Good afternoon, everyone. Welcome to CCALAC's ICD-10 Implementation Best Practices webinar, held today, Friday, June 19th, 2015. My name is Raymond Ople. I am the Health Center Controlled Network Project Coordinator here at CCALAC. And this webinar is an initiative of and supported by our HCCN program. And I will now turn this webinar over to Dr. Despina Kayichian, the Chief Medical Director of Venice Family Clinic.
Thank you, Raymond. Good afternoon, everyone. So as Raymond mentioned, I'm the Medical Director at Venice Family Clinic for a little bit over a year now, and today I will share with you the work we have done at VFC so far to prepare ourselves for ICD-10 implementation, and I'm hoping by the end of it you'll be able to gain some tips and pearls that you will take with you to your organization, because if anyone is counting, ICD-10 will be implemented in 103 days, 11 hours, and probably 1 minute by now. So it is coming. It has been delayed, but not this year. And for me, my journey with ICD-10 started at VFC, at least started actually before I got hired, like a year and a half ago. And to be exact, on the 2nd of January 2014, I sat down with Liz for my job interview with her, and we were chatting about many things, and we talked about how important it is for any organization to prepare for ICD-10, because otherwise the impact, the financial and other impact, productivity impact is so huge. So, and I told her that with the organization I was working with at that time at St. Jude Medical Center, I was the physician champion for ICD-10 implementation and working with our consultant and the project manager, and I told her if I get the job, I will probably lead the ICD-10 implementation at the clinic. So I got the job, and over the next few months, when I would think about ICD-10, two things would come to mind. The first thing is how huge the work is. It's pretty daunting, and I was having a hard time wrapping my head around it. So I looked at it and I said to myself, the only way we get the job done if we chip at it one bite at a time. The other thought that kept coming to my mind is how different my new workplace is from the previous workplace I've been at. And I am a nephrologist by training, and as a nephrologist for almost 20 years, I spent most of my life in hospitals, and 80% of my day would be spent in a hospital setting. And for you, I'm stating the obvious that community clinics are very different from hospitals, but I truly did not know how drastic the differences are. And it's very important for me to point out the difference to you today, because for me it was very important to see the difference in front of me and to put it in front of me to guide me through my ICD-10 plan. So looking at this slide, in a hospital or a medical group, you have a clinical documentation specialist, and those are usually nurses that review Medicare charts, but the hospitals have gone to actually ask them to review almost all patients' charts. It is a concurrent chart review, and they give concurrent feedback to the physician about their documentation. Hospitals and medical groups have coders who query the physician about any question for documentation and coding before a bill is dropped. For hospitals, it is very important that the severity of illness is well represented, and it is called, in a hospital setting, it's called case mix index, and a group for Medicare patients called HCC. And it's important for them to capture that because their reimbursement is really dependent on it. So for all these reasons, hospitals and medical group put together a very strong infrastructure that supports the physician's documentation. So in parallel, when I looked at Venice Family Clinic and I asked my colleague and peers around me about their clinic as well, there's no clinical clinical documentation specialists available, and pretty much there's also no coders, and some of the clinic have coders, but a small number of them, certainly not to support all the providers available in their facility. So as we all know, the other significant difference is that our payment reimbursement structure does not take into consideration currently the severity of illness to the most part. I know we're starting, and I know we do have the P4P and other program, but in general, it is not as vital compared to hospitals. So as a result, community clinic, we have a weak infrastructure supporting the physician's documentation. I should make a correction here. It's the physician's documentation that we're talking about and not the physicians or providers. So it was, for me, it was important to look at these differences and to base my plan and our strategy at VFC based on this fact. So the conclusion is that any ICD-10 work will need to hinge on around provider education. Also, as you know, providers, and at least at VFC, we do not get feedback regarding our documentation coding. Therefore, when we think about success or preparation for ICD-10 implementation, the financial risk is very high. So these are what we had in front of us going forward preparing for ICD-10 at VFC. In terms of resources we used, these are the two main resources. PMG is a consultant that we partner with early in December, and they are mostly webinar and web-based support in terms of resources, project management resources, education resources, and I'll talk to you a little bit more detail about that. And CMS over the last few months made available to providers a much larger amount of resource, and we'll have the chance at the end of the webinar to look at it because I do believe it has become pretty helpful, and we did use a few documents from that website. So what we will not be talking about today is ICD-10 content. Today we'll be mostly talking about the process that we followed step by step in order to prepare our organization for ICD-10. The content is too huge and too overwhelming, but I wanted to mention to you just a few fun facts that you probably know some of them already, but worth noting one more time. So 14,000 codes currently are in ICD-9, and this will be up to 69,000 codes in ICD-10. But not to make it sound too overwhelming, 40% of the new codes are related to laterality, and 50% of the new codes are related to musculoskeletal disease. And in reality, in a family practice setting, in a family practice setting, whether clinic or group, we will be using a very small number of these new codes. For us, though, I'll open a parenthesis here. At VFC, we do have few orthopedic doctors and few rheumatologists, so this is definitely a big impact on us. What I like to mention, the last one I like to mention and maybe expand on it a tad is the mapping. I've heard over the last few months a lot of talk about mapping and that we should just look at the ICD-9 codes and do mapping and we'll be okay, and that's really not true, and it's actually not recommended for provider to use mapping for their documentation or their coding. And the answer is really simple. Just think about it. If you are trying to map codes in ICD-9, then you will have only 14,000 codes in ICD-10, and it makes no sense because the purpose of ICD-10 is to expand the codes, to make it more specific, more detailed. And if you're using mapping, you have done nothing to the specificity and the detail that is being asked from us for ICD-10. And I give you a couple examples in terms of the difference with the number of codes in ICD-9 and 10. A femur fracture has 16 codes in ICD-9, and it has 1,530 codes in ICD-10. Just one simple fracture. And the other thing that's worth mentioning is that are some diseases that actually have less ICD-10 codes, less number of codes in ICD-10. And these are hypertension disease. We started with 33, and we now have 14 with ICD-10. And ESRD and stage renal disease, we have 11. And currently 11, and will be having only 5 in ICD-10. Diabetes, we currently have 69 codes, and in ICD-10 it's 239 codes. So these are examples to show you why it is not recommended to do mapping in ICD-10. The content of ICD-10 is huge. So when you think about educating your providers and other a healthcare worker in your organization, it is important to remember that. It is impossible to remember the codes by heart. So what you'll need to focus on are the principles, and there are many principles. They probably will need to remember that eventually, but I mentioned here a couple of them, like you need to code for tobacco use with certain condition, and some example of these conditions are cardiovascular disease, atherosclerotic cardiovascular disease, stroke, otitis media, believe it or not, also pneumonia. You need to code for tobacco use in that when you code for pneumonia, and hypertension. So there are many conditions where a tobacco use is necessary for coding in order the code to be compliant, and it's important to remember that. Another pearl to remember is that there's an insulin use code right now in ICD-10, but you do not use it in type 1 diabetes mellitus, which makes sense because you cannot have a type 1 diabetic who is not on insulin. So the insulin use code is only used for type 2 diabetes. And it's worth noting that there's one code for immunization, and you will discern the difference between immunization by using the CPT codes for those immunization. And talking about CPT codes are not changed with ICD-10. Something important to remember, because your dentist, if you have dental services, use mostly at least our dentists use mostly CPT codes, and they use very little ICD-9 codes. So that is, a relief, because not much has changed and nothing has changed in CPT codes. Last thing to note for ICD-10 and public health scholars and epidemiologists are very excited to see that social determinants of health will be captured very nicely with ICD-10. So back to our journey at VFC. In December of 2014, we signed a contract with PMG, and we started the pre-planning phase. And essentially, we started looking at the website and see what are the recommended different steps in terms of project management for ICD-10 implementation. And I'll share some with you today. And started brainstorming here and there, nothing formal. But we knew what we needed to do from looking at these resources, and we started the work essentially in January with the ICD team forming then. For another recommended step for ICD-10 was the communication plan, and then putting together a timeline, discovery phase, and impact analysis that I'll mention in details later in my presentation, and along with what you see right now, which is action plan and education plan. So these are the steps that were recommended. And what the gray steps are the steps where we have not completed yet. The education plan is actually in between the light gray and the black, and I don't know if you appreciate that it's dark gray because we started the education plan, but we have not completed yet. We have not touched yet the last 3 steps, but hopefully within the next month we'll be able to complete them. So now I'll be talking to you in details and mentioning more granularity for our process, how we what we have done so far in terms of each step. Forming the team, was the first thing we knew we needed to do, and we asked ourselves, what are the areas most impacted by ICD-10? And also, whether with casual conversation or with during our brainstorming sessions at the beginning, we came to the conclusion that there's a lot of similarity between the EMR implementation process and ICD-10 implementation. I'll mention some of them to you later on. Obviously, EMR was much more intense and much more costly, obviously. So it was something, though, a foundation that we were able to build upon. Our EMR team at VFC is called Change Management Team, and they were meeting for the last 3 years on a weekly basis, and they continue to meet on a weekly basis. So we thought this is a forum where we can insert ourselves as ICD-10 team in those time slots, and we actually stole a couple of their time slots, and now they meet every other week, and the ICD-10 team meets the other weeks. It was important for us to choose a project leader and a project manager, and most importantly, we made the ICD-10 an organizational priority, and that was very important to us. So this is the team. These are the team members. Dr. Margarita Louisa is our CMIO, and she's definitely on the team. She's the one who was gracious to give us her slot with a change management meeting change her meeting to every other week, so we can meet every other week ourselves. We have our IT application manager, nursing manager, COO. We have an EMR trainer, supervisor. She's actually attending the webinar, I was told. And our coordinator supervisor, we call coordinators our referral specialist. And Rosa Ortiz, she is our supervisor, and she played a huge role in our EMR implementation, and we pulled her to our team to help, again, using that same foundation. Front desk and call center supervisor was initially invited to be on the team, but later we realized that the front desk or the call center do not actually deal with diagnoses at all. So she was pretty happy not to attend one extra meeting a week, so she's not part of the team anymore. And the other two is the billing supervisor or manager. They attend the meeting. One of them attend the meeting, and myself. And now I am the project lead, and you will see that we don't have an official project manager. It was a bandwidth issue, and between Rosa and me, we kind of share the project management as well. So I mentioned to you those two resources that were very helpful to us. But I would like to add here that Dr. Louisa, our CMIO, her experience, her knowledge are really fundamental to the success of this process. And I want to give her full credit and more than full credit for that. So this is our communication plan that we put together, divided into internal and external. For our internal communication plan, we presented to the boards on 2 occasions at least, telling them that we are in full bore preparedness for ICD-10 implementation. We also emailed to VFC everyone I believe 2 minutes YouTube video, and you have the link here. And it's again taken from CMS website. It's a cute kind of animated video that explains in very simple language why ICD-10, why we need to implement ICD-10 and what it entails in terms of laterality and all that, and a little bit of details and specific documentation. It was fun, and most people watched it. We currently present an update on ICD-10 at every organizational meeting, and we have our large management meeting every month, and we have site meetings every month, and every organizational meeting we talk about ICD-10 and we give an update. So it's in front of them almost all the time. For our providers, and I will mention that in details later, we send them on a weekly basis, and we've been doing that since February, educational slides. Also on a monthly basis, we mention ICD-10 by giving the providers a quiz and going over the material that they would have received that month. We chose not to conduct a readiness survey for obvious reason. No one was ready at all for ICD-10 at our organization, so we didn't think it was relevant for us. But the PMG referred to it as potentially helpful in larger organization. In terms of our external communication plan, it's very important that we connect with our vendors, NextGen and other. NextGen is our EMR vendor, our payers and health plan, MedPoint, and registry. And I mentioned here that this communication is ongoing and not 100% completed yet. So we put together a timeline, and whether you're able to see the details, I have to admit that the timeline is a double-edged sword. It's important for us to make sure we stay on task, but it's a little bit discouraging when we realize that we're a little bit behind. But I think it's for any project, it's vital to keep us on task. And you can see that we put together our team in February and January. We started the 1-minute provider training that I will present you in a little bit details later in around February. We'll speak also in more details next about our impact analysis that is still ongoing right now, our work plan, education plan, and budget plan. So clearly it is a lot of work, and we have been doing it for a few months, but tons left. So impact analysis, I will spend a lot of time today talking to you about it because I consider it the foundation and the heart of the work. And from this, your education plan, your action plan, will be put together. But you need to have a robust and very solid impact analysis that will guide you to your other steps. So what does it entail? What is impact analysis? I mean, it's a fancy word, but it said what it actually is, impact. So it studies the impact of ICD-10 on your organization. And to simplify it even further, what we did, we went to each department and we asked the manager if they are using ICD-9 codes in their daily workflow. And if they are, we gathered every form. Whether they are or not, we still gathered every form that, every paper form that each department is using, and it's surprising to see that despite EMR, we are still using a lot of forms. And we also have backup forms because the last year I've been there, we have a couple times a downtime more than 2-3 hours, and we needed to resort to the paper forms. So there's still some forms for that purpose. So looking at the department, if a diagnosis is used, gathering the forms, and for that we used a tool from PMG called Discovery Interview Sheet, and all the discovery sheets were gathered in a binder. And this is a partial view of the discovery sheet, but essentially what it says is you're looking at your department, the different areas in your department. You're looking specifically at where a diagnosis information is used, what are the forms used, and whether there's electronic media used in your department. And so we looked at all the departments, and we gathered this information and we put it together. The impact analysis is a very long and slow phase, and this has been our experience as well. It's taken us 3 months, and we're almost at the tail end of it. But as I mentioned earlier, it's very important because from the impact analysis, you will be able to put together your action plan, your education plan, and your budget. So these are the departments that when we looked at, they are using ICD-10. So they are affected and impacted by ICD-10 implementation. So every department had the discovery sheet and all the forms, and I will give you an example of the final sheet that we pulled for all the department in a few minutes. But I just want to mention to you here that when potentially difference between VFC and your clinic is the fact that we have a large body of volunteer providers. We currently at VFC have 27 staff providers between part-time and full-time, but we have 48 volunteer providers. We have 2 primary care providers that are volunteer, and we have 46 specialists that volunteer at VFC with different, every day at different capacity, once a month, sometimes less often. But it is very important for us to look at again this large body of providers and try to figure out how we are able to reach out to them when it comes to ICD-10 education. So you can read here the different the other departments that I'm sure you probably we share, all of us, in common. So this is the example of pretty much final. It will probably take few tweaking, but that's the final impact analysis grid with some action plan. And I will go over this just in a couple of details. The question that we ask ourselves is, who is impacted, who is affected, which is essentially saying which department is affected, what is the impact on a scale of 1 to 10, how bad this department is affected, what is the action plan, what are we doing about it, by when, and who's doing it. And you'll see that for our staff providers, the impact is 10 out of 10, and these are our plan for staff provider education and who's doing it and what are the pending element to that. For our volunteer specialists and primary care providers, our action plan is still evolving, and we had a brainstorming meeting about it last week, and I'll mention that in a little bit more detail later on. So for every department, the coordinators, the dental, we put this impact analysis grid for every department that you saw on the previous slide, and this way it's in front of us, we know who's doing what, and we know what we're doing for every department. So I'll elaborate a little bit about the education plan. For our staff providers, as we talked about, this is the most, this had to be the most robust action plan we take and we have. Our providers are the one putting in the diagnosis code, and we currently have no coders. The billing staff will take the code that the providers enter and will translate that into the billing department. So it is very important that we lean on our providers to pick the best code. Therefore, the education is focusing on more specific documentation, and the education started a long time ago in February with the goal to think of it as, if you're taking a class, you don't cram for the final, just the last 2-3 days of the class. You're essentially studying every week, and hopefully you're looking at the slides every week, and there are some quizzes here and there, but by the end of a 6-month stretch, you'll have a somewhat good understanding on the content, because as I mentioned earlier, the goal is not to remember it by heart. The goal is to learn the nuances of it, and to know what you're supposed to look for when and you have a certain diagnosis in front of you. So PMG provided to us something called 1-minute provider training. It's a little bit misleading, because it doesn't take 1 minute to look at the slides, but for 2 subjects, it'll probably take 30 minutes to look at it and try to digest it. But these slides have been emailed to providers, as I mentioned, and with the hope that they're looking at it. And I do believe that they are looking at it. I'm not sure, possibly not in a great detail and in great scrutiny, but when we're given the quiz, many of them are actually able to grasp the concept. And with the quiz is, again, not about, it's about the concepts, about the general principle of it, and not about the details of each diagnosis. The other thing that PMG made available to us is an app for the smartphone, and we recently encouraged them to download it on their phone. So this is a screenshot of the 1-minute provider training, and there would be some explanation and a little bit of guidance. And what I like about it is these tables. So in a snapshot, we can look at the tobacco use and we can see the different potential codes. And instead of scrolling through the different options and not knowing what exactly you're looking at, I personally like the way it's laid out like that. And this is the app. It has a search function, but I made it clear to the providers recently that it is not an ICD-10 search. This is a search for the different, for the 108, I believe, slides that, not slides, the 108 topic that PMG has available for those slides, and you're searching essentially those topics. And you can search, you'll see in the next picture that you put in hyper and it brings up the 3 potential diagnoses. So it's, again, you have in front of you the table the way it is in the slides. So if you had looked at the slides and you have it in front of you on your smartphone and you're familiar with it, it's easy to look at the different diagnoses and choose one, hoping to decrease the time for inaccurate diagnosis search that way. So some other things we're doing for staff education. The last quiz 2 weeks ago, I realized that only half of the provider turned it in, and I was a little bit concerned that they're not engaged anymore with the education. So in 2 weeks, our next provider meeting will take in 30 to 45 minutes to discuss the content and maybe go over the quiz and go over again the big general concept of ICD-10. And there will be another 2-hour session in September that's already planned, 2 weeks probably before ICD-10 implementation. So hoping to consolidate the knowledge at that time. Also, because of the poor participation at the last quiz, we're hoping to send a survey to providers to asking them. We already have a couple feedback telling me that they didn't think the slides were helpful. So again, trying to see if it's not working, what else we can do to mitigate that. We did run a report of top 100 and top 100, I apologize, ICD-9 codes, so we know what are the diagnoses that we need to focus on in our education. We are planning to building favorite and next gen before go live, and we are hoping to use ICD-10 codes also before 10/1/2014. And Quest is going to make available to us some cheat sheets, and those will be also another tool. Last night I was reviewing those slides and I smiled when I saw this this slide, because there's one thing missing from the slide, and Dr. Louisa removed it, and I smiled when I realized she did that. And what's missing is the IMO. I wanted to mention the IMO, and it's funny because her and I, after we saw the presentation, the IMO presentation, we had mixed feelings about it, and she said she didn't think it was going to be helpful. I thought, even if it helps a little, why not? And I had asked her earlier this week to review my slides to see if she has anything to add, or if she wants to take away something, and so she took it away. And I thought it was funny last night to realize that. But I would like to mention it because I think it is also an option for you and us to use in order, again, to streamline the process of entering a diagnosis for our providers. So our biggest challenge we're finding trying to look at this impact analysis is our volunteer physician. And it's a challenge because I'll just tell you how they currently document and encode. I preface by saying they're a wonderful asset to our organization, and they deliver high quality care, and they're mission driven. They're with us, many of them, for years and years, and our patients love them. It's a mix of retired and practicing physician, but most of them do not document in NextGen, and we scan their note, and our coordinators, our referral specialists, when they check out their patient, they look at their documentation, they enter the code themselves on a paper fee ticket. So do you see the challenge here? If they write ankle pain, the coordinator with the current ICD-9 would know the diagnosis, they're used to it, and they put it on the fee ticket. But now with ICD-10, if they write ankle pain, this is a non-compliant code. They have to be more specific, which means the coordinator will have to go to them, and we'll have concurrently, without really, before they leave, they will have to ask them to be more specific in their documentation, and that is a huge task and very time consuming. So we are concluding that we will empower the coordinators to be able to have extra time to go and ask them about more detailed documentation. And obviously our coordinators will need to have their own education to allow them to do that. But I think we concluded that our specialist volunteer providers will need to get some sort of education, whether specialty focus or cheat sheets. We need to reach out to them, and we met this week about it. It was the first time I realized how many we have, and I have their email, and my goal today is to send them an email asking them what have they done and what they're doing to prepare for ICD-10, and telling them that we would like to offer maybe a couple dinner meetings or maybe some one-on-one and specialty focused education, and we'll be getting their input through a SurveyMonkey that Margarita will send to them after I send them my introductory email. It is concerning because, as I mentioned earlier, we do have we have 4 orthopedic doctors and 2 rheumatologists who work with us, and 50% of the new ICD-10 code is related to these specialties. So it's going to be challenging. Our behavioral health services, unfortunately, they're busy as we speak with EMR implementation. So starting in August or maybe in July, we'll start sending them through PMG. They do have behavioral health specific slides. We'll send it to them. We already looked at the top ICD-9 codes used by this department, and we'll try not to map, but we're a little bit concerned because this is a department that have not used ICD-10 too much. So again, they have been on paper until now. And we feel that a face-to-face training with them, maybe a couple sessions, will be very important. The dental service is likely one of the easiest departments because, as I mentioned, it's mostly CPT code that they use. But one opportunity we found out when we were doing our impact analysis is that they only use one ICD-9 code. So clearly for billing, we definitely need to use more than one, and that reaching out to the dental roundtable was very helpful to expand this list. Mapping might actually work for this department because of the limited diagnosis, and hopefully we'll start education for this department and for our dentists in August. Our nursing staff use ICD-9 for standing orders, for PPD, for chest X-ray orders, for positive PPD, for wound care. So, but again, the list is short. And again, in this for this department, mapping will probably work as well. We will start their education in August, and we'll probably use the cheat sheet for them as well. So the impact analysis for IT and billing, I showed you here a screenshot from CMS website, and that's the URL address. And these, it's a template library, and these documents are very, very helpful. We use them for our IT technology vendor assessment with NextGen, and our billing department also use them for communicating with the clearinghouse that we use. So I refer you to these documents. They're very helpful for these 2 departments. So billing and finance department, what is the impact analysis there? Well, it's huge because it is very important that your billing department is able to give you a quick feedback regarding rejected claims or any spike in denials that you see after ICD-10 implementation. Currently, in our clinic, our workflow does not allow this quick feedback, but we are hoping that over the next few months we'll be able to change that. Our billing manager told me that she will be able with her team to give us prompt feedback if the claim is denied, so we can improve our documentation and change the code. But I feel this is really essential to your organization to be able to do that, because otherwise the financial loss is really not bearable. We are currently planning, and she's probably there by now, to hire a part-time coder. Possibly the part-time coder will be able to help us with some chart audits. We're hoping we'll be able to do that. But coders are very valuable for ICD-10 implementation and audits. It's very, it's really, it would be very good if you have them. PMG, when we were looking at the material, they recommended that we talk to our payers and make sure that our contract with them is revised to reflect some accountability on the payer side or clearinghouse side, in case they're not compliant and in case we incur losses because they're not compliant, but honestly, we don't have the bandwidth to do that. And finally, our reporting process is very important, that we update our diagnosis to make sure our reporting process are not impacted with ICD-10. So what I went over so far is essentially a somewhat detailed explanation of what we did for our impact analysis for every department. And if you feel that you want to hear a little bit more about the other departments, I'm happy to email you about what we have done. I felt that those were the biggest challenge we had, and was worth sharing it with you, so you learn from our experience as well. So what's next for us? As I mentioned, we are finalizing our education plan. Mostly what I didn't mention to you is that I highlighted in yellows the department where we have the most work and the most challenge, and our volunteer special providers and our coordinators are very challenging for us right now, and our education plan need to be very tight for them as well. When we looked at the project management tools for PMG, they recommended that we put a budget way long ago. We have not done that. We are currently, so our budget, the step for our budget is we definitely still not mature, but one thing that I will mention to you is that it is very important that you budget for decrease in provider productivity for a realistic period of time, because it's very well known, even in Canada, that's been on ICD-10 for years now. They have not, the healthcare providers have not gained the productivity that they had before ICD-10 implementation. So it's a well-known fact that we will incur a significant loss by this loss of productivity. All of us, probably hospitals, are the most affected, but I truly believe clinics will be affected as well. The figures that I've heard the last year or two that I've been involved in ICD-10 is between 20 to 30% loss in productivity. I can see that in hospitals because the hospitals are also implementing the ICD-10 for procedures, so this does not affect us. We're implementing only the diagnosis changes. But when we met in our senior management team last week and we talked about the budget for this coming year, I proposed at least a 10% reduction for 3 months, and you can imagine everyone is not happy about that. But I propose that you be conservative, and if you didn't decrease your productivity as much, then good for you, but I think it's realistic to take that in consideration. Testing is very important. Unfortunately, we were not able to participate in the last CMS end-to-end testing because we did not have our internal structure in place, but we're hoping we'll be able to do internal testing very soon after we upgrade. So finally, I just want to tell you that I feel that we did so much, but there's still so much to do. And I sure pray that we did it right and that the impact is not too bad on our organization. Thank you very much. So we'll be happy right now to take questions. All right. So I'm going to say right off the bat that looking at the volume of questions that we'll probably won't be able to go through them all today. What I was hoping to do, I was hoping to show you CMS website, and I'm not sure if you prefer to, I do that, or you prefer that I answer the questions. Sure. Let's quickly go over CMS website because it is, Raymond, let me drive. I think it's very valuable, and they keep adding to it every almost every week. This is the template library that I mentioned to you that has all the tools that you need. It has videos that these are the short videos that you can share with your organization that are fun and short and explain to people at a high level what is ICD-10. It has webcast with specialty webcast of family medicine and practice. So this is 46 minutes. This is OB, 28 minutes, ortho. I haven't gone through them myself. I plan to. But honestly, the webcasts that I have listened to through CMS website have been very, very helpful. It's, again, it's not about remembering the content of ICD-10, but about learning the concepts, and those webcasts are very helpful in that way. Some physician perspective, and you'll see here, I will not go over that with you right now, but what I want to mention is something that I saw recently is interactive case studies. And they're actually fun. These are the different case studies. I'm hoping that they will add more, but these are some, there are a few that they have, and you can play with them and see if you get it right, and see if you're, how ready you are. But Build Your Action Plan is another tool that I try to play with, and if you're a small group, a bigger group, and again, these are just so you know that this website is geared for small practices, but I find it very, very helpful to use their tools that they have here. This is a here they guide you through the journey, and I find this very I found it helpful. I only looked at it a month ago, but I said to myself, oh, this would have been helpful to me at the beginning. But they give you some tips on how to do your planning, your assessment, your implementation, your testing, so so you can put together your action plan this way. And like I said, I think they have enough interaction that potentially there could be another resource for you. And what I recommend is that you sign up to receive their update, and if you go to the home page, I believe there's a place where you signed up to, so we're actually 10 hours and 9 minutes now. So you sign up to receive emails from them, and again, I find that also very helpful, and you get whatever addition they make to their website. So let's go back to the questions now. So does VFC, a question from San Kim, does VFC use any external ICD-10 consultant engaged in providing training and gap analysis? The consultant that we use is PMG, and they only provided web-based tools such as documents and such, and they did have actually some webinars, mostly geared to project management, and the education tools that are mostly the slides. They do have a monthly webinar that I think mostly are geared toward project management. We currently do not have anyone coming to speak to us. Both Dr. Louisa and I feel that we have enough knowledge with ICD-10 content and concepts that we're probably able to, along with the slides that we have, to guide our providers. What is the strategy? A question from also Kim. What is the strategy with additional clinical documentation resulting from additional laterality specificity details of ICD-10 codes? I'm not sure I know what the question wants to ask. I think at the end of the day, something that I haven't mentioned yet so far today is if providers want to be non-specific in their documentation, the way they are in ICD-9, they can be non-specific in ICD-10. And I say that because you can document an ICD-10 compliant code, and because even in ICD-10, you can document a code where it says non-specific. So there are non-specific codes for ICD-10, and how you engage your providers in better clinical documentation, it's a little bit challenging for us because you cannot say that, I mean, you're not like a hospital where we know that the hospital will lose millions of dollars if their employed physician is not documenting well, and our physician, although they're employed, they do know that the financial impact is not as huge. I have to admit that our providers are amazing. They're very engaged. They're great, and they've been very collaborative in terms of and cooperative in terms of realizing that the documentation need to be more specific and more precise. And hopefully, we all know that the change is not going to happen in a day or a month. Probably the documentation will not get optimal in a day or a month. It probably needs several months. And the effort that we started for ICD-10, we need to continue it probably for months and months to come. Let's take someone else. Yeah. All right, a question from Eugenie Lewis. Do you have recommendation for planning for ICD-10 training and implementation for behavioral health? What we are doing, we have our slides about behavioral health topics from PMG, and we are using them to train our behavioral health providers. The behavioral health providers have less of a challenge because obviously the content is not as intense as the medical providers. I personally, I'm sorry, but I have not looked at other resources for training outside what we have available through our company. A question from Anu Srivasan. Is it possible to share the 1-minute provider training slides? It seems like a wonderful idea. Unfortunately, I don't think PMG will allow us to do that. It's their property. I'm sorry. Question from Mika Ayoki. Can you tell us why you thought that IMO won't be helpful? Yeah, great question. Like I said, I would definitely go for it. And Dr. Louisa, our CMIO, what she likes to do, we will be upgrading and testing our next version, hopefully the next couple of weeks. What she wants to see if after this upgrade, the search function in NextGen is any different from the current search function. She wants to see if NextGen has put together any innovative tool to help us with ICD-10, and if not, we'll probably go with IMO. But the answer to your question is yes, the IMO is very helpful to guide us to a very specific diagnosis, and it's awesome when I looked at it. But then afterwards, I thought about it. If every time we go through the IMO, it's probably 6 or 7 clicks, and already NextGen is I find it a click-heavy EMR. So I felt that it's way too many clicks, and unless you save let's say you did the search about congestive heart failure. So you go through the different steps and probably at least 6-7 clicks. If you didn't save that into your favorite after the search, what will happen is if you try to look for it again, you have to go again through the same process and the same number of clicks. I thought if we do that and save the diagnosis, it would be good. But if the providers have to go through it every single time, a lot of clicks. And again, we already get complaints from our providers about NextGen being way too click heavy. Question from Lauren Richard. Despina, so Margarita believe the IMO could cause any issues, or does she simply feel that it's not worth the expense? I personally think the expense is well worth it. I think it's definitely worth the expense, especially if it can improve our productivity a tad. But I think, again, she was concerned about the number of clicks, and she was concerned about the fact that you have to go through them again and again and again. Question from Sandra Mentes. Did your vendor or billing agency provide you access to ICD-10 codes to test claims? Our billing department is still, they're still finishing up their impact analysis, and I looked at one payer last week, and the answer was yes. But for us, what's more important is that we wanted to do internal testing with NextGen ourselves, and to me that's even more challenging step, and that I like us to get through. But the answer was yes, that we will be able to do that. I'll take a question from Dan Baxter. Do you feel having a full-time coder is a good thing for clinics? Yes, full-heartedly. I truly believe that the time has come for community clinics to have coders. It's a good investment. It's time. I think the clinics lived a long time without coders, and coders are very helpful to support physician documentation. It's very important right now to work on our documentation to reflect the patient's severity of illness, and again for when we implement ICD-10, it's very important we get feedback from coders and others how we're doing, because currently we have absolutely no idea how we're doing. And I apologize, this was the last question. I hope you enjoyed the webinar, and we'll try to go over the rest of the question and answer them as much as possible. Have a great day.
So thank you, Dr. Kayichian, for your great webinar presentation, and thank you all for attending today's ICD-10 Implementation Best Practices webinar. Thank you very much for your time, and have a great day.